With all the imaging available to us, forgetting about what Native is developing, but why is osteoporosis not diagnosed at the rate that you would expect it to be diagnosed at?
Yeah, sure. So I think the big problem in osteoporosis is it's a silent disease. And that means it really has very few signs or symptoms until you fracture. Patients don't experience any symptoms, so don't seek care for it. There are no signs for doctors to pick up in their physical exams. So you have a condition which is silent. You also have a diagnostic test, which is a DEXA scan, but outside of the hospital setting, reimbursement's gone down over the last few years. It means it's becoming unsustainable to run DEXA services. Traditionally, osteoporosis is a disease that's been managed in primary care. The fact of the diagnostic tests is difficult to access for patients.
Do you think the data that's necessary is easier or harder to get in the US relative to the UK?
The data sets that are very challenging to build, particularly in the US, are data sets that require more longitudinal data. We have longitudinal data on a population of 65 million people.
All right, welcome to the next Scale Community Technology and Innovation podcast. I'm joined by Will Briggs, the CEO of Naitive. Naitive is focused on developing innovative technology within the bone health market, and particularly interested and excited for the conversation on the back of some recent discussions we've had on innovation within the broader ortho MSK space. So I think this goes well with that. So Will, welcome to the discussion.
Thanks very much. Appreciate it. Thanks for having me.
So maybe a quick overview of Naitive. Why focus on the bone health market? What is the broader market context that drove you to this area of innovation, and what within this market are you looking to do?
Sure. So I think two things really. We looked at it from a clinical need perspective and also a commercial opportunity. Maybe if I start with the commercial opportunity that we saw, and then we can speak to the clinical need. As you know, orthopedics is a huge part of healthcare. 17 trillion of healthcare spend in the US, about 10% of that's in orthopedics, and about 50% of orthopedic surgeons are employed by hospitals, and about 50% are in private practice. And, like you'll have heard from many of your guests, reimbursement orthopedic surgeons receive for their primary hips, primary knees, things that have historically driven their revenues, is going down. So the market has really responded in, as I see it, like three ways. First thing is site of service. How do orthopedic surgeons do the right cases in lower intensity surgical environments? A movement towards ambulatory surgical center settings. Second thing is ancillary services. So, these private orthopedic groups are adding things like imaging, CT, MRI, physiotherapy, physician-administered drugs, other opportunities for the practices to make revenue, to make them more sustainable and more diversified. And then obviously the third thing that's happened to the market is consolidation. Private equities come in, and it has created really interesting distribution channels within private orthopedics in the US. So the thing that we focused on is ancillary services. How can we grow ancillary services for our customers? That is the commercial need. The clinical need in bone health is, if you think about orthopedics, bone stock and the quality of that bone, that is the fundamental thing that orthopedic surgeons operate on, right? And if you have osteoporosis, that is low bone mass, you have poorer bone health. And that means you're more at risk of fractures, be those fractures from falling or be those periprosthetic fractures from orthopedic surgery. The problem in the osteoporosis space, or at least one of the problems in the osteoporosis space, is that the majority of patients with osteoporosis are undiagnosed. So in the US, it's something like 75% are undiagnosed. That includes really even after a fracture, by which point you have, by definition, severe osteoporosis. And in the UK, it's probably closer to 90%. So you have this condition which is very, very prevalent. About 60% of orthopedic patients have low bone mass. It causes devastating consequences. Depending on which statistics you believe, the cost to the US healthcare system is somewhere between 20 and 100 billion. That's fragility fracture cost. And it's devastating for the patient. So if you have a hip fracture, your 12-month mortality approaches 25, 30%, which is worse than many cancers. So we have this devastating clinical condition, which is massively underdiagnosed on the one hand, and deeply affects orthopedics. And on the other hand, we have a move to grow ancillary services in orthopedics, send more patients for imaging, send more patients through PT, put more patients on physician-administered drug. And the osteoporosis patient is a chronic musculoskeletal patient, essentially, who is suitable for nutrition optimization, physician-administered drugs, physiotherapy, etc. So it was really the coming together of those two pieces, the changes in the markets in private orthopedic practice group, emphasizing ancillary services, and the osteoporosis patient, who is an ideal candidate for ancillary services, who's also at significant risk. And we want to change that.
With all the imaging available to us, forgetting about what Naitive is developing, but why is osteoporosis not diagnosed at the rate that you would expect it to be diagnosed at?
Yeah, sure. So I think the big problem in osteoporosis is it's a silent disease. And that means it really has very few signs or symptoms until you fracture. What that means at a patient level is that patients don't experience any symptoms, so don't seek care for it. And because there are no signs for doctors to pick up in their physical exams when they see patients, and no symptoms that patients have complained of, doctors don't prioritize it. So you have a condition which is silent. You also have a diagnostic test, which is a DEXA scan, which, I don't know if you follow DEXA reimbursement, but essentially in the hospital setting, DEXA reimbursement's okay. Outside of the hospital setting, reimbursement's gone down and down and down and down over the last few years. And that means it's becoming unsustainable to run DEXA services outside of hospitals. But of course, traditionally, osteoporosis is a disease that's been managed in primary care. So you have a diagnostic test, which is now in a location which is disjointed from where the typical diagnosis takes place. So those two factors, really, the fact it's silent, the fact that the diagnostic tests is difficult to access for patients.
So let's talk about what Naitive is doing to change that. So what specifically is Naitive looking to develop to improve the diagnosis of osteoporosis and the improvement of bone health?
So big picture, we want to build a bone health service in a box, which we can take to a private orthopedic practice group, plug it in, and it uses technology to allow them to find patients and manage them more efficiently and more effectively. The first part of that bone health service in a box, and we think about everything in terms of care pathways from screening through diagnosis, treatment, and management, is a product we call OsteoSight. So we got breakthrough device designation for OsteoSight about 18 months ago. We've just submitted OsteoSight to the FDA now for 510(k) clearance. And what OsteoSight does is it takes advantage of imaging collected for other reasons. So if you take the orthopedic workflow, X-ray is the front door imaging test that almost every patient with an orthopedic complaint will receive. It is almost like the starting gun in many ways of investigations for orthopedics. And the signal for poor bone health, the changes in microarchitecture and bone mass, which correspond to osteoporosis and osteopenia, are present in those X-rays visually, but they're just hard to spot. A radiologist or an orthopedic surgeon who's reviewing an X-ray can see bone loss when it gets to 30 to 50%. That's quite extreme. What our technology allows us to do, which uses computer vision machine learning, is look through those X-rays and spot changes in bone mass much, much earlier so that we can flag patients in their routine orthopedic workflow for further evaluation by bone health.
Okay. You mentioned OsteoSight. What about the other products that you're looking to develop? I think I saw Prognost.
Prognost, yeah, that's in Skunkworks at the moment, along with a few other things. But essentially, if you think end to end now, and the reason to think end to end in technology delivery in healthcare is because if you deliver products in series along a care pathway, the effect size compounds. You end up with a true synergistic effect. Is we start at this point, screening. Okay, so we've now found a bunch of people who are at risk of poor bone health. We need to better evaluate those patients, so assign them risk more effectively. And once we've assigned them risk effectively, we now need to treat them. Now, at the moment, the best way we have of measuring risk, and when I say risk, I mean fracture risk here in bone health, is a DEXA scan plus fracs. That is basically an algorithm that takes into account various demographic features plus your result from your DEXA scan. And it gives you a 10-year major osteoporotic fracture or 10-year hip fracture risk. That is what we use to assign people to treatment at the moment. The problem with that, and the problem with DEXA is, if you look at the two components of fracture risk, as I see it, your bone strength and your falls risk isn't really considered at that point properly. And then bone strength, well, DEXA measures bone mass. Bone mass actually explains less than 50% of bone strength. Bone strength is a composite of bone mass, but also bone morphometry and bone microarchitecture and quality. So when we think about diagnosis and really prognosis of fractures here, is, can we build a more holistic description of fracture risk by taking into account the other features of bone strength that we don't at the moment and other features of falls risk? And then if we think through to the downstream care, so now you've diagnosed these patients, you've correctly assigned them to risk categories. Well, what do you do with them? And you've now increased the volume of patients coming through. So you've got to offer a solution that helps manage that volume. So two things really: automation to increase the way that volume is managed, but also treatment's not done very well in osteoporosis. You should put patients onto calcium, vitamin D if they need it. It's not really done. You should consider patients for bone loading exercise programs and also programs to improve their proprioception and reduce their falls risk. That's very rarely done. And then when you elevate a patient into pharmacological treatment, at the moment you have bisphosphonates, first line drug, cheap as chips, right? And you give them to patients that will maintain their bone mass. The problem is patients don't take it. Like all chronic disease meds, compliance is terrible, approaching 30 to 50% at 6 months. So you automate that downstream care as far as you can, and you also focus in on improving drug compliance, improving patients getting onto the right PT programs, improving patients being treated with the right nutrition. You do all of those things and you can have a very, very significant impact on fracture outcomes. And that's our ultimate goal.
So it sounds like you want to start with OsteoSight, which is early diagnosis of bone health conditions like osteoporosis, and over time you want to migrate more into care management, so not just diagnosing the patients but also helping to manage their holistic care. Is that sort of the progression?
Yeah, that's right. It's the idea that we can come along and bring a bone health service, a set of tools which supercharge their activity. We don't want to run the service ourselves, but we want to make sure that service is run really effectively, really cost effectively, to deliver fantastic economic outcomes for the practice and fantastic clinical outcomes for the patient.
So let's talk about the practical implementation of the product from a care delivery perspective. So a couple of questions on OsteoSight. Is the technology that you're introducing finding a new variable in a given image? So I'm a new patient, I show up and there was something in the image in the x-ray that wasn't previously seen that's now being seen that gives an indication of osteoporosis? Or is native technology OsteoSight doing a better job of tracking the change in imaging over a period of time for a given patient? So on the first scan, when I show up, not necessarily going to yield any new findings, but if you come 5 times for 5 scans, Native's going to do a better job of tracking the trend and the change in the bone density.
So the answer is the former. We look for the DEXA measure of bone health, bone mineral density, T-score in X-ray. And what's key here is we do this automatically and opportunistically. So that X-ray is taken, the file ends up in PACS, that's the picture archiving communication system, that's where X-rays and MRIs and CTs are stored. We pull it, we analyze it, and we push a result to sit alongside the X-ray where someone is at risk. So it does the former. We are working on the latter, and that comes back to like moving towards a diagnostic, right? Something that is precise enough and repeatable enough that you can take a measurement and track change effectively over time, rather than just bucketing patients into a high and a low risk group.
When I think of a lot of these AI-driven technologies, they require massive data sets to be able to analyze and sort of compare trends and then use that data to make useful conclusions with new data sets. So first studying large data sets and then applying it to the micro, the next patient that comes in. Is that part of what went into developing Native, amalgamating a large data set of orthopedic imaging to study, or how did you go about the development of the technology?
Yeah, you're exactly right. It's pulling together a large training data set that represents different ethnicities, different genders, different BMIs, different ages, and making sure the algorithm as you train it has been exposed to really the whole breadth of the images it might expect to see in clinical practice. Then you can do, and I'll leave this to the machine learning wizards in our team, but you do a bunch of little tricks that enhance that data set to perhaps overemphasize features that you want the machine learning algorithms to learn. And then it learns to identify patterns in the imaging which correspond to low bone mass.
I'll come back to that in a bit, and I'm curious. I know you're based in London, and so I'm curious to get an international perspective on different countries' readiness to access data to drive improvement in clinical care. But leave that aside for a second. The DEXA procedure, the imaging that you talked about, that's got declining reimbursements. Why is it that reimbursements are coming down? I mean, you describe a situation where early intervention yields better outcomes for the patients and avoidance of cost to the system. That all sounds positive. Why are the reimbursements coming down? Was it just a very high starting point? What do you think is driving that?
That's a really good question, and truthfully, I think it's a trend that has left me scratching my head. And I think if you look or speak to many public health experts, it's left them scratching their head as well, because DEXA, as a screening tool, is cost effective. It's potentially even cost saving. So for the system as a whole, it makes sense to do. I think that we're starting to see changes in the direction that are saying, okay, well, we might not be reimbursing as much for DEXA. And remember, this is primarily in the office setting, right? The reimbursement for DEXA in a facility hospital setting is still pretty good. But we're starting to see new technologies come in, like Medimap's trabecular bone score, which layers on top of DEXA, gives you a little bit more information than just bone mass, and that's also reimbursed. Whilst the baseline reimbursement for DEXA is going down, we're seeing other technologies come in which allow you to build that back up. But honestly, I'm not sure why. You'd have to speak to the insurers on that one.
And is DEXA, is it a similar reimbursement in the hospital HOPD environment versus in the outpatient setting, or is DEXA reimbursed at a more reasonable level and sustainable level in the outpatient market?
I'd have to come back to you on that one.
Okay. So there are different ways to think about applying technology. So, for example, there was a technology that improves retina imaging scanning, and in that case, the counterpart was primary care. So, allowing primary cares to do an expanded range of services to diagnose conditions and then send off to retina providers, but only for those patients where it was relevant for the appropriate retina care. It sounds like you're selling or planning to sell to orthopedic groups rather than sell to an urgent care clinic or a primary care to allow them to handle an expanded range of service. Is that the way you envision it, or do you see selling to both markets?
So I think you're referring to IDXDR. They had a fantastic business model, as you described it, right? It gives primary care the opportunity to offer a wider range of services. In my world, which is the world of image analysis, the customer has historically been and will continue to be for a very long time radiology, right? Radiology departments in hospitals, independent diagnostic test facilities outside of them. And we looked at that as a market, and I guess we felt that this technology that we've developed doesn't deliver enough value to the radiology department. Now, just coming back to the adoption of technology, let's say we were going to sell to a hospital. In the early days of us as a business and our product being launched, the first customer we would have would be the radiology department. If we don't deliver value to the radiology department, and the value that we would deliver to the radiology department would be we found more patients that are suitable for example, a DEXA scan, which is relatively low, we're then competing with every other radiology AI algorithm out there. The value our technology delivers is really to a health system, right? So you find patients with poor bone health in a hospital setting. Those could go through endocrinology, rheumatology. They can be treated by PT, etc. But when we first come into a market, we don't get to speak to the hospital C-suite. We have to start with the department heads. And I think what we decided with orthopedics is an opportunity to build the evidence base that would allow us to circumvent that conversation when we come to sell to hospitals and go straight to the CFO of the hospital and say, look, we're going to deliver fantastic outcomes for your patients, and we're going to improve your bottom line here. And if you think about private orthopedic practices, you can kind of think of them in this context as like little health systems. They've got their nurse practitioners and PAs, they have physios, they have imaging, they have their own EMR, and they have their own PACs. They sometimes do physician-administered drugs. They have this ability to take advantage economically of the cases we find there and then. And the surgeons who have the partnership model are economically incentivized to adopt it. So we think of them as They are the orderers of the imaging. They're the interpreters of the imaging. They're the people that benefit from the downstream care economically. Great little place to start. Once we've built the evidence up there, that gives us the right to have conversations with hospitals and health systems and say, at that CFO level, don't think of this as a solution just for radiology. Think of this as a solution across your institution.
That makes a lot of sense. Where are you in the process of commercializing the product?
So we've got about 15 to 20 pilot sites lined up now. We call them our early adopters or design partners. They are testing the product. They're kicking the tires on the product. They're telling us what they want different in the product, which will be for version 1.1. So we've got a group of great sites lined up. Hopco, who you mentioned earlier, they're one of them. We're also working up projects with University of Iowa, WVU, Rothman, various other orthopedic institutions. Once we have our FDA clearance, we'll then be able to start selling the product. So this first phase really has been about proving its clinical value and the potential economic utility of the technology in their context.
Do you have any views on when you expect FDA approval?
Hopefully, fingers crossed, we'll have our FDA clearance before the end of the year.
That's great. What for those that are less familiar with the process, how long does it take in total? Let's assume that happens by the end of the year. How many years long is the process? From
starting with a fresh algorithm and saying we're going to start developing this.
Yeah.
I think it depends on where you are as a company. It is that generally viewed that you could take from scratch, no funding, no nothing. You've got to fundraise because it's expensive to take something through regulatory approval. Typically $3 to $5 million is what they say the cost is of bringing a piece of SAMD to market. And you're looking at sort of from probably as short as say 6 to 9 months. If you've got something really ready to go already, to as long as 2.5, 3 years if you're really starting the science from scratch.
Given that you're based in London, do you anticipate selling your solution in the UK or in Europe, or are you primarily focused on the US market for the foreseeable future?
For the foreseeable future, we're focused on the US market. I'm from the UK. I was a doctor, so I worked in the NHS. I have this crazy British love of the NHS. I would like to be able to sell it in the UK. I think a few things need to happen for that to make sense. First, obviously, we'd have to go through the UK regulatory process. And remember, going through the FDA, we're accessing a market of 340 million people. Going through the UK regulatory process, we're only accessing a market of 65, 70 million people. So there's, the cost associated with accessing a smaller market there. Does it make sense? And then secondly, from an adoption perspective, I'd like to see more products being adopted in the NHS, more technology products. The third thing for us is it's kind of a volume problem, right? So what our tool does is it finds people with poor bone health and finds a lot of people with poor bone health. In the US, you have the structures and the slack in place to be able to treat those patients, to be able to make money from those patients. In the NHS, if I turn up to a site and say, I'm going to find you 20,000 patients with poor bone health, primary care would kill me. They're already stretched incredibly thin. So until we have the building blocks for the downstream products in place that will allow us to manage that patient volume in an automated way, in a very efficient way, I don't think the NHS is a viable market. Now, sure, once we have the end-to-end pathway ready and we can bring that to the NHS and say, we're going to find people with poor bone health, we're going to help you manage that increased volume so you don't have to add lots of heads, new staff, and we deliver much better outcomes for you, it becomes a brilliant market. But we have to get to that point from a technology perspective to be able to deliver the clinical value that we want to deliver.
Yeah, that's interesting. So the supply shortages in the UK market relative to demand, or the high wait time, said differently, actually is a disincentive to innovate because you're going to be driving more volume. And so, that the first thing is to answer how do we solve for the more volume. That's interesting. What about in the US in terms of that question, back to the gathering of data? How do you go about getting the data set within this orthopedic MSK space to be able to develop the solutions that you're looking to develop? Does that come through these pilots, or is that something that you begin prior to the pilots, accessing some large data set to test out an algorithm? Walk us through how that works.
Yeah, the latter. So you can access data in a couple of different ways, right? There's publicly available data. Those sort of data sets tend to be pretty low quality. And if you have a specific use case that matches what the data is, then you can make use of it. The second thing is signing data sharing agreements with hospitals. That is a pretty slow process. We've done it. We've got our own hardware on site at hospitals. We have like 3 server clusters, things like that in hospitals where we can do machine learning. It's a slow, painful process. The other way, the third way, and increasingly my preferred way, is working with data vendors, companies like Gradient Health, companies like SegMed that have relationships with hospitals already. They've already gone to the effort of anonymizing and aggregating that data, building cohorts for you, and to just be able to come in and purchase access to that data. That is effectively become the cheats way of, collapsing an 18-month data access program and process down into weeks.
Do you think the data that's necessary is easier or harder to get in the US relative to the UK or comparable?
It depends on the use case, right? So take estimating bone mineral density from x-rays. You really need something as a label for poor bone health, and you could use DEXA, you could use QCT, for example, and you need x-rays. So you need patients or subjects who've had an x-ray and some sort of diagnostic test within a given time window, probably about 6 months, 6 to 12 months. Bone mass is pretty stable over that time. That data set where the time frames between your label and your imaging input are short, you get from anywhere. The data sets that are very challenging to build, particularly in the US, are data sets that require more longitudinal data. Now, that's where the NHS is fantastic. We have longitudinal data on a population of 65 million people. If you're in one hospital and you want to follow up what's happened to a patient who you've perhaps operated on, you can request hospital episode statistic data from those individuals and gather the information of what they had before, what they've had after, wherever they are in the NHS, like whether they've had another operation, another site even. So that longitudinal data quality is very, very high in the NHS. But I think the bars to access it are also high. That doesn't really exist. There'll be a few places where it exists, but not to the same extent, because patients are much more mobile. We've got one closed system in the NHS. In the US, you've got a couple of closed systems, but people leak from them pretty quickly.
I know digitized records was an issue in the UK. I think on the GP side, it was pretty strong in terms of digitized records, but at the hospitals, it was slower to digitize. Is that something that the UK has now made progress on?
Definitely made progress on. I think, again, it depends on the site you're talking about. And it depends on the data you look. If you're looking for literal EMR records, then yes. I mean, I used to work at a hospital where the medics wrote paper notes. The surgeons put their stuff free text into one system. Drugs were ordered on another system. Pathology was viewed on another, et cetera, et cetera. Lots of disparate systems, some paper notes still. That system is now fully electronic. But if you're looking for aggregated statistics and events that have happened to patients, HES data is pretty good. And increasingly more and more hospitals are digital. That's been the trend. There will be some sites that have been digital for a very long time, and you've got fantastic data on as well. It's that ability to link hospital data with GP data, that is very, very powerful.
So back to Native, let's maybe shift gears and talk about implementation. So let's fast forward to later this year when you're FDA approved. What do you anticipate the implementation process to look and feel like? Is this software that sits on top of the X-ray machine at the orthopedic practice? How long, how expensive will it be to implement? How disruptive is it to implement?
Yeah, so the ways you can implement technology like this, you could implement it onto the X-ray machine, you could implement it on PACS. And perhaps the reason radiology was the field that AI first took off in healthcare is because the beauty of PACS is DICOM. You have a very standard format for storing imaging. People might not always code that right, and they might not always abide by the DICOM standard, but there is a DICOM standard for imaging. It's stored in a certain way. PACS in images are retrieved from PACS in a certain very standardized way as well. So our technology interoperates with PACS. To speak to PACS, you need query retrieve access, things like that. Those are standard protocols across all PACS. So it's really a set of setting up the the part of our software which communicates with PACS with the relevant permissions to be able to speak to it. And it's really as simple as that. So we've set up at sites before on 2 30-minute phone calls. You just need someone who understands the systems, PACS in particular, and the other systems at their end. So we've tried to make our technology as easy to install as possible. Now, where we want to take it to is we want to integrate with the orthopedic EMRs, because orthopedic surgeons, their NPs, their PAs, they live in their EMR. You go to a practice and you see an orthopedic surgeon request an X-ray. The X-ray will be taken. They'll pull the image up in PACS, and then they'll open up Athena, for example, and dictate their report into Athena. Whereas in radiology, the result might be put into the RIS alongside the imaging, essentially. So what we want to do is, as well as the result going in and sitting alongside the X-ray for everyone to view, we want to get the findings into the clinical inbox of the relevant bone health lead within a practice.
How receptive are these provider organizations, whether it's a large orthopedic specialty network, whether it's a health system, how receptive are they to piloting an innovative technology within the space? Is it something that they're very cautious about? Is it something they're very excited about? What are the barriers for them to get going? Is it culture? Is it risk aversion? Give us a flavor for what that pilot phase looks like, and how easy or hard it is to execute on.
So for the pilot phase, or the research pilot, however you want to think about it, you obviously got to agree a clinical protocol. That means finding someone who's willing to be a principal investigator. That's normally pretty easy. It's pretty easy to find a clinician that's excited about this space and sees the value in that. Once you've got your protocol together, you then need an agreement between yourselves and the clinical site about doing the research project or the research pilot. Again, those agreements tend to be pretty easy to get across the line. I think in part because they're common. A lot of research is done in these contexts. We tend to not ask anything crazy, right? We just very vanilla in what we suggest in those contracts. And then once the contract's about to be signed, there's always the conversation with, well, you need to speak to our IT guy to make sure, or girl, to make sure that this is possible and this is doable. And then it depends a little bit on the size of the orthopedic group. If you're talking to a very, very large, sophisticated group like an HSS, there's a lot of red tape, as there rightly should be, right? They'd be a big target for cyber attacks. So they want to make sure that when you come in, you've got your penetration testing, you've really thought through your security risk assessments, and they want to tick all of those boxes off. The smaller groups who don't necessarily have their own in-source IT person, that might be a separate IT company that's providing that. That's really a conversation along similar lines, but generally it's a little less rigorous, and they contractually put more of the onus on you to make sure that patient data is protected. And one of the things we do when we do that pilot is all the data we anonymize. It's an extra level of security. And then I think you've got the sort of sweet spot in the middle for me, which is groups that are pretty big. They've got a relatively mature IT system. You can have a very sensible conversation. You can demonstrate, because you have to do this for FDA, right? There's cybersecurity requirements for FDA submissions. You have all of this information. It's then having that conversation, showing them what you put in place, making sure they understand where there is risk, where there's not risk, how that risk is mitigated. And then they'll take a sensible view on, okay, on the balance of probabilities and based on what's been done, are we less secure by working with this company? And inevitably the answer is no, right? These groups send data to radiology groups, to primary care, all over the place, and their security is likely to be much, much lower than the security standards we are held to.
What percentage of your pilots are hospital system groups versus non-hospital orthopedic groups?
Yeah, again, it's a maturity of information security, information governance in a hospital system which exists. And with that, layers of bureaucracy, right? Committee A, B, C, and D, form A, B, C, and D that need to be filled in. I think, as I said, the medium-sized orthopedic groups where they've got someone really good in IT who understands this stuff really well, who you can just speak to directly as a company and say, this is how we do things, this is how we reduce risk, this is how we prevent patient data being leaked. That's the sweet spot for us. We've come across some hospitals which do things fantastically well, and we're very, very lucky to be working with them. But the bigger the institution, often the more bureaucracy.
And how do you think about commercializing and selling the product? So I'm always interested in this mix of, groups that want to adopt new technologies versus a lot of technologies are point solutions. So this is addressing bone health. I'm imagining that a diversified MSK platform or an orthopedic division within a hospital could have dozens of these technologies for different conditions and different use cases. Do you think that the best pathway to sell this product is directly to the provider group or the health system? Are you envisioning selling through, you mentioned EMRs, you mentioned PAC systems, are you envisioning them as channel partners to sell? There are groups, I interviewed somebody, the CEO of Ferrum Health. They're sort of providing a foundational layer that will serve as a governance platform for rolling out different types of AI-driven technologies in the clinical space. What do you think is the right way to, from the service provider side, sell, and from the provider side, adopt these technologies? Many disparate point solutions, consolidation, channel partners, governance platforms like Ferrum.
Yeah, so I think the answer really depends on whether you're looking at this as from a hospital perspective or from a private orthopedic practice perspective. Hospitals have been adopting AI in radiology for a number of years now. Most of them are partnered with one or more radiology platform like Blackford Analysis, and being an application on an app store like that or on an imaging platform like that makes a lot of sense. What we found with private orthopedic practice groups is, even the very large ones, the idea of introducing these types of technologies is a relatively new concept. And therefore they don't have any or many of these point solutions switched on. That's part of our strategy, which is to sell to these groups, sell and deliver clinical value with an application, then more applications along a care pathway, earning us the right to sell them more things along other care pathways, and ultimately position ourselves to be that platform for this customer segment.
I want to end with a question on your outlook on Native, where you want to be in 5 years, 10 years, you pick a time horizon, but paint a picture for how the company's technology evolves to be that in-a-box solution. So we're starting with OsteoSight, and you've got other products that are a little bit further behind. What does it look like when it's fully built out?
Yeah, so if we go at 5 years, what we want to be doing is delivering solutions for bone health, osteoporosis, for joint health, osteoarthritis, and for muscle health, sarcopenia. End-to-end care pathways to allow orthopedists to manage these conditions very, very effectively. So a very complete suite of solutions for the orthopedic context.
And the complete suite of solutions is primarily on early diagnosis or expanding into the broader portions of the care delivery ecosystem?
Yeah, the latter. It's managing key care pathways for key conditions end to end. So that you can go to a group and say, you can spin this up. We're going to find more patients for you. We're going to allow you to manage those patients more effectively and deliver better outcomes for your patients and better economic outcomes for your practice, for not just osteoporosis, but osteoarthritis, sarcopenia, and then other diseases.
And truly the last question, do you see, as you do that, as you execute on that vision, that you want to stay a software company, or do you see that in order to manage these conditions, getting into a combination of people-driven services plus technology will be required to execute on that vision? Do you see yourself getting deeper into care management, remote patient monitoring that might require, even if it's not at MD level, but people-driven services combined with technology? Or do you want to just be software and you'll sell to orthopedic groups and orthopedic divisions of hospitals?
What we want to do is we want to bend the curve on these chronic diseases. And it would be foolish for me to say that can be done with software on its own. That doesn't work in healthcare. The question is, will we find the right clinical champions within groups to allow us to provide them with the software and then provide the human expertise to deliver that? Or is that something we'll have to ultimately provide ourselves? I don't know at this point, is the truth. I think what I do know is if we get in there with software and we build out that data layer along care pathways, we will know where the pain points are. We will know, therefore, where there's an opportunity to introduce additional headcount into a care pathway to deliver better outcomes for patients. And then we can have that conversation with the group. And I think it will very much be a group by group thing. Some groups will say, we want to do this all in-house. Where are the problems in this care pathway? Show us and we'll deal with them. Other groups may say, well, actually, we don't really want to deal with bone health. We want the benefits of dealing with bone health, but you deal with bone health. And then we have to think through how we would do that as well. So you've asked a very tough question as the last question, because it's something we talk about a lot internally. Are we a pure software play, or is there a world where we become tech-enabled services? And I think for now we're playing with software. If we see that we can't deliver the clinical outcomes we want to deliver, then that's the opportunity for us to start thinking through how we introduce headcount into that space and the power of a human, right? Not everything's going to be automated away by ChatGPT type algorithms.
Yep. Makes a lot of sense. Will, I want to thank you for the time. I really enjoyed the discussion, and congratulations on what you've built so far, and good luck with the pilots and the rest of your FDA process. I look forward to following the company's trajectory and hopefully to FDA approval by end of year.
Thanks very much. Really appreciate it.